Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi there, and welcome back to Unraveled. I'm David Kaufman, my colleague here,
Yay.
Eileen Ruhoy, to another episode hot off the press for YouTube. Where are you, YouTubers? Come watch us. Subscribe, please. Spread the word. Tell your doctors it's free now. The docs can watch it.
That's right.
Okay.
They don't have to pay for it.
Right. Okay, so we're going to do more on tick-borne disease, part 9.
Well, the rest is on our Patreon page.
Right.
So this is actually the first tick-borne disease on YouTube that we're doing.
And we're still trying to figure out how to get all the Patreon episodes onto YouTube. Another conversation. I'll start cursing if I talk about it, so I won't talk about it.
It's capitalism.
Yeah, it's capitalism. We ain't seen nothing yet. Wait till Monday.
Oh, my God.
Okay, so vector-borne
No, not
disease.
Monday.
Yeah, Monday's Inauguration Day.
No, it's not. Is it?
Yeah.
Isn't it MLK Jr. Day?
Today's my son's birthday. I got to call.
Jake?
Adam.
Oh, Adam.
Yeah, Monday. Isn't that cool?
Yeah.
MLK Day and Trump Inauguration Day on the same day. Poor MLK is spinning in his grave. All right, sorry, folks. No politics. But life is politics. How can we not
Life
do
is
it?
politics.
Okay? How can we not?
Why did I think the inauguration was the 26th?
No, it's the 20th, always. I don't know what's on the 26th.
I don't know what's wrong with me today.
Okay, so we're
My lymphatic system is not functioning.
So vector-borne disease or tick-borne disease, a broad, controversial, nightmare, rabbit hole topic. As my patients know, I generally introduce it by saying, I hate this topic. I hate thinking about tick-borne disease. But that's like saying I hate thinking about
breakfast.
Mono or no. I like thinking about breakfast. EBV, reactivation,
right.
or COVID. Okay. So
I find tick-borne disease, I have to say, I find it challenging, for me at least, who doesn't do it regularly.
It's challenging for me too.
Really?
Oh, yeah.
Oh, that's good
and
to know.
And it's one of those diagnoses, like so much we talk about and do and learn, that keeps changing. Mm-hmm. I mean, I would say my conception, my perception, my thinking about tick-borne disease has changed every 2 weeks.
Well, every time it changes, you're going to have to update me because I always go by what you tell me.
Okay.
So if you've changed it several times since you've told me, then I'm doing something wrong. So you need to keep me updated.
So I'm trying to think where to start. So, so tick-borne disease, excuse me, when I use that term, and I purposely use that term rather than saying Lyme disease, because I think that's one of the reasons we're so screwed in the world of tick-borne disease. All of the world, all of the ID people, all of the boarded infectious disease people, and a lot of the patients think Lyme disease, and they forget there's other diseases, and therefore the research and the understanding of the treatment outcomes has been completely distorted. Because if you think it's Lyme and it's not Lyme, you're going to make a big mistake.
Right.
Okay, so generally for me, the tick-borne diseases are Borrelia, which is Lyme, Babesia, and Bartonella. Okay. There's Ehrlichia, there's Anaplasma, there's Heartland virus, Rickettsia, and there's probably 100 other things those ticks transmit. But this is what we know. Okay, those three though are the ones that cause the most trouble and are the most difficult to treat. And I believe what the evidence more and more shows is that those three are just like EBV and HHV6. They are not eradicated by our immune system when you get infected, always. In other words, that's not the universal outcome. You get infected, and you may not have any symptoms whatsoever, and you don't get treated because you didn't have any symptoms, you didn't know you had a tick on you, and then 30 years later you get COVID and bam, suddenly you test positive. How could that be? There's only one way that can be that I can figure out. You had it like EBV when you had mono, and 20 years later you have reactivated EBV, and you can have reactivated Borrelia, Bartonella, and Babesia. Mainstream medicine will not agree with that. IDSA, the Infectious Disease Society of America, will absolutely not agree with that. But I see it all the time. Tanya Dempsey sees it all the time. The whole kind of smaller masterminds world of tick-borne disease doctors, we see it all the time. There's just no way around it. I don't know how to change that dynamic or that way of thinking about it. So if you accept that model, it changes the entire way of thinking about the disease, the treatment, the management, and the outcomes.
Right.
Okay? Because in the same way that we know EBV is like that, we never look to cure EBV. We can't cure it. We have no drugs that kill EBV. What we aim to do is suppress its viral replication in the hopes, literally, that the immune system is restored to its homeostatic strength and keeps it locked up. And I believe that's what we need to look for in tick-borne infection. If one accepts that, I guess I'm doing a little domino effect here, then that means you're not treating for cure, which is a scary thing. Most patients do not want to hear that. You're treating for control and for reestablishing latency. And for me, what that then means is I don't know how long to treat. I don't know how many drugs it needs, and I'm not sure when to stop, when I'm done. It's a nightmare.
I think the minute that patients can understand that we have lived in coexistence with viruses since the beginning of time, and we find that dance with it, of putting it into dormancy and us allowing our lives and our bodies to live on while these viruses just sort of hitch a ride.
Exactly. And I think this is the same thing. And one example of that, let's just talk Bartonella. So Bartonella is not, its main vector is not ticks, okay? It is transmitted by, I have a list somewhere, but at least 20 other vectors, 20 other organisms and animal reservoirs and spiders and, everything can transmit Bartonella. Yeah. And the proof of that is if you do Bartonella serology, antibody testing, which I've stopped doing for this reason, it's positive 80, 90% of the time in every patient, right? And I suspect that's true in me and in you and everybody. And that means we were infected, and right now somewhere is latent Bartonella, okay? And it may become an infection issue if something happens to our immune system. So then the next question is when to look for it, okay? And
do you do it at the initial?
No.
Okay.
Almost never. Yeah. There's a lot of exceptions, but
if there's a very high history
that's what I'm about to explain.
Right.
Yeah,
okay.
Yeah. So, because it's a rabbit hole, I don't want to dive down that rabbit hole and put that poor patient down the rabbit hole unless I have a compelling reason to do it. Because at the same time, the testing is not perfect by any means. Yeah. Okay. So part of my initial history is always a tick-borne disease risk history. Do they have a high exposure risk? And that is high enough for me to think it's worth going down that rabbit hole then. And number two, is that really as compelling as dealing with their POTS? I'm making an example. So risk exposure history, where did you live your whole life? Don't just tell me you lived in New York the last 10 years, New York City, Manhattan. Where did you live your whole life? Where were you born? Where did you go? What did you do in summer? Did you go to camp? Did you, before you got sick, go hiking and camping or fishing or hunting? All the things that place you at risk for bugs getting on your body, basically. Right. Okay. And as a physician, this is a suggestion to physicians, don't fall into the trap of saying, well, they only have ticks in New England, so I don't have to worry about it. California doesn't count. Oregon doesn't count. That ain't true. Okay?
Right.
This is everywhere, all right? The other risk exposure is animals, pets, cats, dogs, horses. Did they have fleas? Did you get scratched? Did you get bitten? Okay. Those are all sources of transmission, especially, especially cats and Bartonella. And then the question is, do you pursue that?
Yeah. And you don't in the first visits, unless there's a compelling reason.
I
you
will,
said.
if I have a veterinarian as a patient, I always pursue
Yeah.
it. Okay, that's an
So if they have a
occupational
high
hazard.
risk occupation,
Yeah, high risk.
if they had high risk lifestyle growing up, lots of camping, lots of hiking,
Right.
that was just what they did.
Right. The other reason I don't pursue it right away is the testing is difficult and expensive.
Yes.
And I already
That's
feel
why I
guilty
struggle with
about
it.
what I'm doing in the first visit anyhow, in
Right.
terms of all the testing I do.
Right.
You know, the labs are usually covered, but some of the other stuff's not. You know, the SIBO kit and the cortisol saliva stuff. So I'll sometimes delay it till the next one, knowing that if they have it, I'm not going to treat it right away until I get their mast cell and their POTS and everything stabilized. So
Right.
I'm not delaying care because I wouldn't respond to that diagnosis yet anyhow. So the testing I do has changed based on what I just said about reactivated tick-borne disease. Okay, if we accept it's a reactivating disease, then antibody testing is less useful because it just tells us that you were infected, but I already assume people are infected.
Right.
I mean, not obviously 100% of the people, but so and because I think the treatment is difficult, I want more evidence before I'm willing to commit myself and the patient to treatment, and that evidence is looking for proof of active disease as opposed to antibodies.
Right.
And I think I separate from a lot of other doctors on that. There's a lot of physicians and naturopaths, et cetera, out there who will, I mean, I know some people just treat based on the history with no lab confirmation.
Wow.
But a lot of people, understandably, because that's kind of how we were trained, they'll treat based on antibody results. And I just don't buy that anymore.
Even if it's just IgG?
If it's just IgG positive.
They'll still treat?
Oh, yeah, yeah.
Okay.
And I used to do that too, all right? But I've gotten much stricter. So now I want direct positives, and that means evidence of organisms actively in the bloodstream.
Okay.
So that would be PCR testing, culture, which we can't really do with any of these organisms, or so-called FISH testing, which is a fluorescent antibody test. And those are tests that are essentially PCR testing you can get at LabCorp and Quest, but I don't use their testing at all. I just find it too insensitive. Conversely, if somebody's positive, even antibody testing at LabCorp or Quest, I immediately will dive in further because it's so rare that if it's positive, something's going on.
Right.
You know.
What about congenital?
Well, I think there is vertical transmission.
Okay.
Yeah.
So is it the antibody that is transmitted, or does it have to be an active infection?
No, I think the infection can be transmitted.
Right. I mean, the infection I agree with, but what about the antibody? Are those antibodies?
I would think that they can be across the placenta, yeah.
And so, but does that then confer infection for the offspring?
Probably, but again,
just the antibody.
Well, if it's literally an infant or a toddler and it's positive, it probably does indicate infection because they have less likely any other source. Little kids like that might not be going camping and hiking and fishing.
Right.
You know.
Right. Okay.
But I would still want the proof, direct positive proof.
Okay. So if you have the direct positive proofs, which you're referring to as actually showing the infection itself, the bacterium, or I guess because Babesia is a parasite, right?
Parasite, yeah.
Yeah. So you want proof of the actual organism,
right.
And that's proof of an active infection, and then you agree to treat.
Yeah, I mean, to put it very simply, it's one thing to have antibodies floating around in your blood, which we have thousands of.
Right.
Okay. It's another to have bugs floating around in your blood. Bugs don't belong in our blood. So if there's a way to prove that they're in your blood,
right,
that means you have direct evidence of ongoing infection, and that I would treat.
Okay.
Okay. And I pretty much now depend on the fluorescent fish staining at T Labs. Partly because I think the guy that runs that lab, Bob Mazziani, is brilliant and has really put an enormous amount of thought and innovation into creating this laboratory testing.
Right.
And what that is this molecular probe that is attached, so to speak, to the fish, the fluorescent stain. And the probe is like a guided missile. It seeks out only Babesia or only Borrelia or only Bartonella, so it's very sensitive. And then he has this kind of microscopy, confocal microscope, I don't fully understand it all, where he can look in the blood and see it. And you can see on the pictures that he sends the red blood cells with little fluorescent dots on their edges. It's pretty amazing and creepy. Okay. And that's considered positive. I mean, he has a criteria, validated criteria for what's positive. So you need more than 1 or 2 dots.
Right.
And then I'll treat based on that.
Okay. And treatment is starting with doxycycline and azithromycin?
Well, let me just say, first of all, that obviously I do want to say this is how I do it.
Yeah.
I don't know that that lots of people do it differently. Ways. I think Tanya Dempsey's approach is similar to mine. Excuse me. And I'm sure that Bob's is. And I think it is where things will be headed. Mm-hmm. Okay, but I want to just say it's not like I have chapter and verse to defend this. There's no good clinical trials. There's papers written, but and there's papers that absolutely demonstrate the whole latency reactivation issue. Okay.
So right. So there are papers. So there has been research that shows that it can be reactivated.
Right.
Do we know COVID can reactivate these tick-borne diseases?
I mean, in my patient population, I see it all the time. After
and
COVID.
We know that COVID reactivates viruses.
Yeah, it causes EBV reactivation. Mm-hmm. COVID disturbs, perturbs, screws the immune system. I almost said it a different way. And when that happens, lots of bad things happen.
Right. Why do you think it's so controversial? I still can't figure that out.
I don't know either. It's ridiculous.
Yeah.
I mean, back in the beginning,
these
are
politics, bacterium.
But
these
now
are
it's like, why are you
politics.
arguing? Why are you arguing?
What politics can be associated with a bug, with a bacterium, with an organism?
Number one, the insurance companies didn't want to pay for prolonged therapy and IV therapy, so they had doctors who did trials with IV therapy and said, no, it doesn't work. Treating more than 21 days doesn't change anything. All those patients who say they get better and then they stop the antibiotics and they get worse, and then you give them antibiotics, they get better, that's hallucination or something. I mean, literally, that's what it was. The Lyme wars are real.
I don't get it, though. I don't understand why we accept other infections and somehow this one had taken this political, controversial hold.
I think it goes back to, a little bit goes back to what we said in a different way about in the previous episode towards the end when we talked about women as patients in medicine. Mm-hmm. Doctors don't really want to listen to patients if what the patient says doesn't fit into what the doctor's perception and organized thinking of for a problem is.
Right.
So if you have an infection and Lyme Borrelia is sensitive to doxycycline and you give it to a patient and they'll be cured, how can there be a population of patients where that's not true? So the patients must be crazy. Right. That's really what it boils down to.
And is there a world, how we do resistance and sensitivities for other bugs? Are we doing that for these bacteria?
We haven't been able to do it.
Okay.
Because you can't culture them.
Got it.
Yeah. I mean, I think that's the next big thing.
Yeah.
So again, going back to the infectious disease doctor nightmare, what drugs work? How many do I need? How long do I treat?
How long, right.
How do I know when I'm done?
Right.
And like you say, how do I even know the ones I'm choosing are effective?
Yeah.
So there has been sensitivity work in vitro.
Right. I was going to say in the T lab, if they're actually identifying the bacterium, I wonder if there's a way that they can
I don't think he's doing that yet, but there's been some beautiful work from Zhang at Hopkins, Northwestern, and Stanford, I think, different groups, and this was part of the whole reason I made this big switch in my head about thinking about this, that showed that the reason that giving antibiotics got patients better, and when you stopped it, they got sick again, and when you restarted it, they got better. So that was what was laughed at by IDSA. The reason is they discovered in the lab that the drugs we use for those patients traditionally, conventionally, azithromycin, doxycycline, et cetera, are only effective against the replicating forms of the organisms, not against the stationary phase or latent phase, which they documented. Okay, so that was a huge step. They actually documented this stationary latent phase concept, like the EBV in B cells.
Wow, that's fascinating.
And they then showed or discovered drugs which worked on the latent phase. And that's kind of revolutionary now, because now we understand why every time I gave somebody doxy and azith, they get better, but when I stop it, they get sick again, because we need to deal with the latent.
And so how do you deal with the latent? What drug works on those phases?
Disulfiram, which is antabuse.
Yeah.
And methylene blue. And this is straight out of their research. And, excuse me, a compounded form of clotrimazole, which people take for thrush.
Oh.
Rifampin probably works on both sides of the picture, replicating in stationary phase. And so what people will do, doctors will do, is alternate between them. Again, how long do you do it for? All bets are off. I don't know. I mean, I'll tell you what I usually do. And you know this, I usually start with azith and doxy. Usually try to go for 1 to 2 months, and then I'll try to switch over to chlorithro and rifampin, again for 1 to 2 months. If the labs were positive for Babesia, I'll use Mepron, atovaquone, and or Aracoda, because the doxy-azith combo does not kill the Babesia.
Oh, okay.
And then somewhere in there, I'll either add methylene blue, or I'll pulse back and forth between the different combinations of drugs. I think the other crucial piece in the conversation is, it goes back to how I've thought about this or reconceptualized it, is if we can't fix the immune system, we're not going to win.
Right.
We're not going to make it better. And I think that's true for EBV. I think it's true for long COVID, ME/CFS. That's why we do plasmapheresis and exosomes and all this other stuff. So how do we, it's a two to tango. We need to try to kill the bugs or knock them back into latency, and increase the competency and restore homeostasis of the immune system.
Okay.
So theoretically, suppressing the activity of the bugs will help do that in the same way when you do with EBV. It helps restore immune function or improve immune function. But I think we need to do more than that, and we have limited tools. Methylene blue can help because it also works at the mitochondrial level, as you and I have discussed. It works on the electron chain transport, and by fixing that fixes the immune function. Okay. Rapamycin can help the immune system by definition, virtually, by improving autophagy. That improves B cell and T cell function. You have a healthier immune system that can look around and go after those bugs more effectively. Again, it goes back to evolution. We have an immune system for a reason. It's a miracle of miracles in our body. And if it's not functioning well, we're going to be screwed. TA1 is now available again, and I'm back on it, prescribing that over and over and over. It is a incredibly effective booster of immune function and natural killer cell function. It does other things too, but that's.
I love it.
Yeah, it's incredible.
I'm very regularly recommending it.
And I'm sort of playing with the dosing because I think it's.
You're going higher?
Yeah, I've recently been doing 900 3 times a week.
Oh, interesting.
Don't know if that's better, but sort of conceptually thinking a higher dose will get a higher level, higher kickstart, and then give the receptors a day off and then do it again. I don't know if it's right. Okay,
no, it sounds reasonable.
So TA1, rapamycin, methylene blue. I'll sometimes treat with add artemisinin, which is a supplement. Not so much for the immune system, but it has efficacy against the organisms, especially Babesia. I do think that plasmapheresis and exosomes help. I've seen exosomes, I believe I've seen, I can't prove it, cause a Herx-like reaction.
I was going to ask about the
right?
Herx reaction.
There's only one way you can have, two ways you can have a Herx-like reaction: antibiotics killing the bugs, or your immune system killing the bugs.
Right.
Okay. So if I have a patient who I know has a history of it, and they're not on antibiotics because I think they're better, I give them exosomes, and they describe, I felt like I had the flu and aches and pains. I felt awful. That's not the exosomes. They're doing their job. That's your immune system killing bugs. That's a Herx. So that's very compelling
that's
evidence
exciting
to me. And then for all the reasons we've talked about with plasmapheresis, yes, it may reduce the burden of organisms, but that's not the main thing. It's useful, but not the main thing. I think it improves immune function by reducing the organisms, reducing inflammation, getting rid of antibodies and all that other stuff.
Yeah, I agree. I think there's so many off-label uses of plasmapheresis that have to do with anything that's attacking the immune system, or anything that's causing the immune system to sort of not be able to do its job effectively, efficiently, and optimally. So I find so much great benefit with the plasmapheresis. Certainly as an adjunct for a lot of things, and obviously with immune-mediated diseases, it can be a primary source of treatment, but it can be a very important adjunct treatment, and unfortunately it's not covered by insurance.
Right.
Right. So, all right, so you don't know how long you keep. So is it just like you follow them clinically and decide, okay, let's wean off? Or
yeah, but see, that's what's really hard.
Yeah.
Because let's say you're a long COVID patient and you come to me and you have fatigue and you have ME/CFS. That's what long COVID is, as far as I'm concerned. So you have fatigue and ME/CFS. PEM, brain fog, POTS, mast cell, leaky gut, SIBO. I can't say any of those symptoms are caused by your Lyme disease.
Right.
Right. And patients will say, well, how will I know when we're done? And I have to confess, well, I don't know, because I'm not treating. It'd be very nice if you came in and told me we have fevers and night sweats and joint pains, and then they get better when I give you doxyazid. I mean, if that happens 1 out of 10 times, I'm lucky. So it goes back, I think, to what we have said in other episodes, where we use a treatment, we think it should help, but the patient says no. But in hindsight, what it is that it did help, but 9 other problems were still there, so they don't feel it helping. So it's a little bit like that. So it's very hard to go by symptoms. If we're lucky and the patient has night sweats, yeah, I'll grab that.
Yeah.
And that works. I mean, that's a useful symptom. So I will usually treat 1 to 2 months and then make a change to other drugs for another 1 to 2 months, and then kind of make some decisions about what to do. I am not doing what some other doctors do when treating for 12 months or 2 years or 3 years. I'm not doing it.
I've had patients come to me who've been on antibiotics for 1, 2, 3 years, and often IV.
Yeah. And I've pretty much stopped doing IV. These drugs are very well absorbed orally. They get very good plasma levels. I think IV is defensible. It's probably not a good word. Makes sense if you have clear evidence of neurologic disease in the brain, just to get the drugs in.
Yeah.
But other than that, I haven't. And I have to say, I've used earlier in this last 10 or 12 years, I used a fair amount of IV in Bartonella patients, and I have to say, I don't think it really made a difference. Not enough of a difference to justify the risk and the hassle and the cost.
Right.
So I just use oral.
That makes me feel better, because I don't think I would ever feel comfortable doing IV antibiotics.
Yeah. So the question that comes up is, how do you know when to stop?
Yeah, and you're basically saying you don't.
I
or at
feel
least
like
not on the onset.
Yeah,
not at the
I feel
outset.
like I don't.
Right.
The obvious answer would be to retest.
Really? So
well, I mean, if you think about what we do in other diseases,
Right, but sometimes testing lags behind clinical improvements, right? So
the
patient might say that they are feeling better and that their symptoms are better, but you might retest and it might still show the same.
And that's exactly what I explained to them. That's exactly right. So
and it's expensive.
Yes, again. So I that's my speech. Okay? And I did retest a few patients and I got back the same results, but the patient was doing well. So I realized, well, wait a minute, I'm not going to act on these results. So why am I retesting?
Right.
It's very expensive. It takes 6 weeks to get if you're using Bob's lab, 6 weeks to get the results. And if there's still some positivity, he is not yet able to quantify that. so he can't say it's improved. He kind of sometimes tries to say that.
Yeah.
So if we can't do that, and if I'm believing that this is a disease that is not necessarily curable, but is suppressible, then seeing an occasional fluorescent dot shouldn't mean that much to me. So therefore, I've stopped retesting. Some patients still want it, and I'll do it. It's up to them. It's their money.
Yeah.
But I explain that I'm not quite sure what to do based on the results.
Okay. So you don't change up the antibiotic if they've been on it for 2 months, you retest and it has the same results. You don't think, well, let's try a different antibiotic.
Well, 2 months I might, because I usually treat for longer, end up treating longer
Okay.
than 2 months. And it's just, and for the sake of people listening, so we said azithromycin, I'm going to just name a bunch of the drugs.
Yeah.
Excuse me, doxycycline, clarithromycin, which is in the same class as azith, has a little bit of different activity.
Mm-hmm.
Rifampin, which is a potential game-changing antibiotic, has great intracellular levels, really can work, especially in Bartonella. It's got a big problem. It interacts with everything. So it's not easy to give, because if our patients, as you know, most of our patients are on 5 or 10 different drugs, rifampin will interact with so many of them. It's kind of like when you give Paxlovid, you have to be so careful of interactions.
Right.
So that's a big problem. Cefuroxime in the sort of cephalosporin penicillin family, penicillin, augmentin, amoxicillin, Bactrim, sulfa drug. They all have different degrees of efficacy. Methylene blue I love.
I love
Because
methylene.
it does so many other
I'm
things.
like a huge fan of methylene blue lately.
I wish they could just de-blue it.
Yeah, I know. Why is it blue? I'm going to ask a pharmacist. Do you know why it's blue?
I don't know why.
I always warn people about their urine.
Yeah. I haven't used as much disulfiram recently. I'm not sure why I haven't. I guess I just haven't felt the need because of the methylene blue. And I'm very hopeful now that it's available again, the TA1 will make a difference. Because I used it a lot until the FDA banned it. And now I'm almost afraid to say they reversed that, so it's available.
Yeah, no, I must have ordered it 10 times in the past 2 weeks.
Oh, yeah, me too.
Yeah, I love it.
You know, it has no side effects,
Mm-hmm.
and it's not outrageously expensive. It's an easy injection, and it works. You know, it really works. Does it work to kill the bugs? No, it works to help your immune system.
Yeah, modulates the immune system and gives it some strength.
And I should add, what you know well is that I often won't even begin treatment until I have better control of mast cell and POTS and SIBO, because
it can be a challenge.
it's the drugs are a challenge, the antibiotics are a challenge, and if they Herx, it's a challenge, and I want them to be in as good a shape as possible.
Right.
You know.
And I sometimes will find it hard to know if I've managed the mast cells well enough, unless patients have obvious mast cell symptoms that now after my regimen, a few weeks go by and they haven't had similar symptoms. Then I think that, well, we've managed the mast cells well enough where we can start other medications. But sometimes it's hard to know.
It's hard to know. Well, at some point I just say, all right, we need to move on.
Right, and then there's a question of the Herx. That's why I'm always sort of curious about this Herx response. Because is that a mast cell response? Because sometimes I don't know, is this a Herx or a mast cell response?
It probably is partly mast cell.
Okay.
Yeah.
Because if you're killing the bugs, isn't that a mast cell reaction to the bug?
Yeah, to the toxic,
So it is a mast cell
garbage,
reaction. Yeah. Okay.
I mean, I don't know if it's been proven, but that's how I think of it.
So
if they have a Herx, that doesn't mean you're not doing your job on controlling mast cells.
Right.
It actually means you're doing your job giving antibiotics.
Right.
I mean,
and so do you treat?
I love if a patient has a Herx.
You do?
Well, because it
even if it's
confirms
severe?
my diagnosis and the
I see.
appropriateness of treatment. I'm telling you, this is a nightmare. So any little thing I can get to make me think I made the right decision.
That you're doing the right thing by the patient. No, I get that. You always worry that you're not doing the right thing by the patient.
Yeah.
So do you treat the Herx? Or do you just let it ride?
Usually, if it's difficult.
Oh, because a lot of patients
I'll
report
adjust
it being
the doses
unpleasant.
down.
Oh, so you'll lower the dose,
I'll lower
and
the
that will
dose.
reduce the severity of the Herx reaction.
And if it's a patient who's, pretty fragile, I'll start with lower doses too.
Okay.
And sometimes you can use, ibuprofen, things like that.
Okay.
Just to temporarily fix that transit.
So you don't treat it as a mast cell response, like with the antihistamines and
well,
things.
They're usually already on a lot. So
right. Okay.
I don't usually add more.
Okay.
But I think the future here is the immune side of the equation.
Absolutely. No, I think, as you know, there's some groups that are looking at persistence of some of these bugs, as being a cause of chronic disease. But I think it's just an immune persistence. Like the immune system is just continuously trying to rid the body, eradicate the body of this
Well, that circles
stuff.
you and I back to our episode from a while back on T-cell exhaustion.
Mm-hmm. Oh, yeah.
So T-cell exhaustion is thought to be, or has now been proven, I think, to be from relentless, constant antigenic stimulus.
Yep.
And that means not just COVID or EBV, but it means Borrelia and Bartonella and Babesia and God knows what other bugs.
No, or not even of bugs, of anything that's an antigen, that could potentially play a role as an antigen, which includes like pieces of our own cellular fragments, which is autoimmunity. But yes, it's just chronic antigenic presentation that ultimately results in the T cells just being exhausted.
Which is why a drug like TA1, tyrosine alpha-1, which literally boosts natural killer cell function, might be the game changer, a game changer.
Yeah, I didn't think of that, actually. That's a really good thought. I'm going to use it more than I even have.
It also, linking the T-cell exhaustion idea to this, it's a reason, it may be a reason that justifies why we don't treat for cure, we just treat for restoration of immune function. Because if you suppress long enough, you suppress the organisms long enough, then the immune system will recover. The T-cell exhaustion is not a permanent. I don't think it's permanent.
It's not permanent.
So if you suppress and the immune system recovers, then it's ready for another battle.
Right.
And you've reduced the burden, and maybe they'll stay latent, and then
we'll send in more troops.
Right.
Reinforcements.
But as I said, I think the future is on the immune side of the equation. What can we do? The problem is that except for TA1, most of the other stuff is big dollars and no coverage. There are supplements that may help immune function. Certainly anything to help mitochondrial function theoretically should help immune function.
Mm-hmm.
I think many doctors will be concerned when they see my patients if I have them on tick-borne infection treatment and rapamycin. Your doctor's crazy. Why is he suppressing your immune system with rapamycin? At the doses we're talking about, it is not immune suppressive. It is immune enhancing.
That's right.
It's
important to recognize that some drugs have different effects at different dosages, right? And I think that that's often lost in the translation of things, of what we do for complex patients. We use certain dosings that have a different effect than what's known about this particular drug, at least the historical knowledge of this drug. Because we repackage and repurpose and relabel and
yeah, exactly.
So I agree.
Going back to history for a second, another piece of history that one can look for is, besides exposure risk, is other histories of infections. So patient after patient, and people after people, not just patients, will say, "Oh, I had a 1-week history of a viral illness with fever and aches and pains." Well, if it's the right risk exposure history, that could have been their tick-borne infection.
Right.
Okay. And we need to remember that most of the time you don't see the tick on you. Most of the time, like 70% of the time, I think it is, you don't get that target
bullseye
lesion.
Rash.
The bullseye rash. You don't get it at all with Babesia or Bartonella. And so it really is a stealth infection, both the way it behaves in our body and the way it gets into us.
I've had many patients who had positive testing and were surprised because they did not have a tick, they did not have a rash. They actually even say they barely went camping, but they did once, twice.
Right.
And
of course, the sad thing, back to politics, the mainstream ID docs and academic docs will say, well, that's just because your testing is ridiculous. You're using these unlicensed
labs
that tell everybody's positive,
Right.
And that's, again, it doesn't fit our viewpoints, so we just discard it. And that's very unfortunate.
It is unfortunate, and I've had negative testing from
Oh,
not
yes.
only T-Lab but IGeneX, and
Yeah.
so it's not always positive.
No, it's not.
Yeah.
It's not. And the high rate of positivity is because you're selecting. I'm highly
absolutely.
selective. I'm not going to send somebody, or I'll resist for a long time sending them if the history is not suggesting increased risk. And it's all about probability testing, which is actually something we're taught in medical school. Classic example is if you do a stress test on a low-risk patient for cardiac disease, the lower the risk, the greater the chance you'll have a false positive, all right, versus if you select for risk.
Right. Well, it's all those statistics that go into like screening recommendations, right? When are you going to screen for something like mammograms and colonoscopies? Right. Absolutely. I mean, you need to sort of select a particular population if you're going to screen for it so that you lower the chance of false positives and false negatives, frankly.
Right.
So,
and taking that history, that risk exposure or exposure risk, I don't know if I can decide which way to say it, history takes 5 minutes.
Yeah.
It's not difficult.
No, it's easy. And it's part of, we do a comprehensive history taking anyway.
Right.
So it's just another couple of questions.
Right.
It's easy. So, well, that was very comprehensive.
Yeah?
Yeah.
I felt like I talked too fast. I'm trying to think of other things.
No, that was really good. I mean, you made very clear. Clinically, actually, you really laid out there how you do this, how you approach it. And I think it's important for me to always hear because you told me you always update what you do and how you think about it. So it's nice to sort of know what you're thinking today, at least. So, but it is what I've been doing. So.
And just as we end, let me use an example. So a patient you referred to me who had a positive test. Okay. So he was on Azith and Doxy when he got to me, because you had talked to me about him. You would put him on Azith and Doxy, and he was all better, much better. Interestingly, he presented with unbelievable mast cell activation numbers. His histamine was greater than the limit of measurement.
I can't get it down.
So I met him, and he said, I feel great. I run triathlons, and the guy is like a maniac the way he exercises. Okay. I said, well, then why am I treating you? Why, what are you doing here?
Right.
So we decided to stop his antibiotics. 3 weeks later, his symptoms all recurred.
Yep.
And it's like, for those of you who don't believe what I was saying earlier about the whole thing with antibiotics, this is a perfect example.
Yeah, no.
Oh,
no, I recognize it when he told me that.
3 weeks later, something's happening again. I can feel it and different symptoms. And I see that over and over and over. Not every time by any means. I want to emphasize one other piece, and then I guess we'll probably have to stop. Yeah. This is more to patients listening, but also if we have doctors, to the doctors. Not all brain fog is caused by, quote, ME/CFS or long COVID. Much brain fog is caused by infection, whether it be EBV or tick-borne infection. I have had patient after patient who get their Doxy and Azith initially, and they will tell me my brain fog is gone. And that's like jaw-dropping.
No, I agree.
Because these are not like nuclear strength antibiotics. These are what everybody takes.
Right. These are run-of-the-mill antibiotics.
Right.
No, it is fascinating when patients report that, because I think we know so little about infection in the brain.
Right.
We only, so yeah, I mean, that's another topic. But yeah, I agree.
Yeah.
I'm always just mesmerized by improvements that patients get from just some run-of-the-mill antibiotics. And I used to think it was about its anti-inflammatory component as well, because it's got the antimicrobial, but it's also anti-inflammatory. But the more I do, the more I see, the more I read, the more I think, the more I'm like, no, I think this is antimicrobial, not just anti-inflammatory. Right. I think it's both. But anyway, so it goes to show you that infection really has a role on brain function.
Right.
So, and it's not all meningitis or encephalitis.
Yeah,
it can be a lot more, discreet than that, and a lot more, subdued.
Yeah, we don't have a good label for it.
Right. So it's just interesting.
Which is part of the reason it's disbelieved.
That is so true, because conventionally things like encephalitis and meningitis, there's a very classic viewpoint of what that should look like and what the symptoms are of that, which are usually much more severe than what a lot of our patients are describing. And yes, it's true. So they go seek care when they go to the ER, they go to the hospitals, they go to their local doctors, and they don't get the kind of care that they deserve.
So, and I know I keep saying we're almost done, and then I think of something else. But again, in terms of what you and I constantly talk about, the interconnectedness, bidirectionality of all these
Right.
pathologies in our patients, if the patient has SIBO and leaky gut, that is causing inflammation and leaking blood-brain barrier and impairing the immune system from chronic activation from the LPS.
Right.
That's going to make the immune system less competent and make the treatment of tick-borne infections and other infections more difficult. That's why it has to be addressed aggressively.
Yeah, no,
Okay?
you're right.
I want to emphasize that LPS, lipopolysaccharide, is the model for sepsis. It's an endotoxin which kills people in the ICU, and they use it in the laboratories to study sepsis. You
That's
inject a little bit of LPS.
It comes from bacteria.
Yeah. Leaky gut is basically LPS leaking 24/7 into your body, into your vascular space. It stands to reason you're not going to get better unless we can treat that.
Treat your gut.
Right.
And which can be hard to do. It's not easy.
No, I agree. It's not easy, but it has to be addressed.
It has to be addressed. And then we can go down the septad again.
Yeah, right. Can't get away from that septet.
No, we can't. And we're out of time.
All right. All right. Well, I hope I didn't overwhelm and exhaust everybody, but thank you very much.
You never do. You're always very clear. I'm the one that's all over the place. All right. Well, thank you for joining us. And
Just tell your friends. I'll do what they do on YouTube. Subscribe. Push that button.
click below.
It's down there. Put that button. All right. More viewers generates more viewers. That's what I'm told. There's some fancy
Viewers begets
algorithm.
viewers.
Viewers begets viewers. So that's why we're doing this. Tell your doctors.
We're trying.
All right.
We appreciate you, though. We've actually had a lot of support from a lot of people who, many of whom are not even our patients. So we are grateful for that. Actually, it always sort of warms my heart when I see someone write like a nice note.
And it's
or
helped
something.
in the office. I have patients that come in, a new patient, and they write their history. I ask for something, and I read it and say, "Oh, this person definitely has been watching Patreon."
Yeah, exactly.
Because pregnancy and delivery, 0 to 2, 2 to 5, 5 to 12. It's like, whoa,
No,
and
clearly.
it really helps the visit.
Yeah, yeah. So see,
thank you.
people are listening.
Yes.
So we appreciate it.
Thank you very much.
Have a great day.
So much.